Hi, welcome to the world of cardiology, the study of the heart. This is Dr. Jaitly. I'll be talking to you in this video vignette mainly about how do you treat mitral stenosis, as I've shown here on the left panel. Now, mitral stenosis occurs when the valve area of the mitral valve is narrowed or it is stenosed. Now, normally the area should be 1.5 square centimeter and above. Anything less than 1 square centimeter area, which is calculated by an echo, a Doppler, which we will discuss at a different time or in a different video, that constitutes a mitral stenosis. Now, mitral stenosis can be asymptomatic or can be symptomatic. Symptoms obviously are exertional dyspnea, palpitations, fatigue, and paroxysmal nocturnal dyspnea, which we talked about, is waking up in the middle of the night, classically around like 3 a.m. or 4 a.m. in acute shortness of breath, till the person actually gets better and then falls back into sleep. The classic signs are the patient has a mid-diastolic rumble with a pre-systolic accentuation, like we talked about in a different video, and then a localized murmur, which is heard only in the left lateral position, with the bell of a stethoscope. And these days, of course, they don't make the bell on the stethoscope, they just have one diaphragm. So applying that diaphragm on the apex of your chest, where the apex beat is, it's a very localized mid-diastolic rumble with a pre-systolic accentuation. The patient is in sinus rhythm. Now, if the patient is in atrial fibrillation, which is an irregular heartbeat secondary to chaotic atrial contraction, as we talked about in a different video, that leads to an absence of left atrial kick, and therefore the pre-systolic accentuation is not present. Just worthy of note. Now, indications for surgery, obviously for mitral stenosis, it's a surgical problem. It does not go away because it only gets worse over a period of time, and the commonness etiology is dramatic, as we know. So over a period of time, it's going to get worse, and the New York Heart Association has helped classify various stages of dyspnea, which I'm going to discuss on different other video presentations. But just so that you know, the class 2 variety, where somebody gets short of breath after walking less than 2 blocks, is a symptomatic mitral stenosis. Mitral valve area less than 1 square centimeter, that's the other indication. A pulmonary hypertension, where one has pulmonary arterial pressure over 60 millimeters mercury, and a pulmonary capillary wedge pressure, PCW we call it, it's more than 25. Now that's significant, signifies and qualifies rather for an indication for mitral stenosis as a surgical measure. A previous systemic embolism, even though the mitral stenosis may be totally asymptomatic or nearly asymptomatic in the individual, but a previously documented systemic embolism peripherally itself qualifies for an indication also for surgical intervention. What are the procedures or surgical procedures that one can resort to? Well, obviously the simplest ones are the balloon mitral valvotomy, where you can go trans-catheter from either the femoral or from the brachial artery route, and drop the catheter within, and as a result you can open up the valve as much as possible with the help of and break these commissures, because remember, mitral apparatus has all these commissures which are now getting fused, and that can be so-called fractured, and as a result you can create a good valve area and the mitral stenosis could be alleviated. Now, this is classically done in a setting where somebody cannot or does not want to have surgery, or is not a candidate for surgery as yet because it's a very early on, and so there are specific indications which we'll delve on a different basis, but balloon mitral valvotomy is one area. A surgical valvotomy, which opens up against the chest, and then you have this actual surgical resection of the valve peripheral structures and the removal of the fibrosis, etc., to open up an area. Mitral valve replacement is more common now, and although mitral valve replacement transcutaneous or trans-catheter wise is becoming increasingly popular, because that's the more recent technology, which I've discussed in a different video. But just so that you know, there are valves which have been replaced for the past several, 3-4 decades now. And the commonest valve, which is I've shown on the right panel, is the Starr-Edwards. This is a prototype, which was one of the first ones. And it had a unique capability where you could actually, the ball inside the cage would go up and down and relieve during the stenosis and regurgitation, during systole and diastole, and as a result, will pretty much maintain a profile of your circulation through the mitral valve, but still had a lot of mitral regurgitation and tendency for coagulation around the valve, and embolism obviously was an issue, etc., etc. But still fairly, done in many developed and developing countries still. Starr-Edwards. Bijak-Shiley is the next prototype that developed, where there was a tilting disc mechanism. So here's a disc in between, and that tilts back and forth, and during systole and diastole, so that the mitral valve looks more open during diastole like this, and during systole obviously it'll close so that the blood can traverse through the aorta here, and the mitral valve will appear closed, which is the Bijak-Shiley type. St. Jude's was more physiological, because now you'd have two leaflets, as mitral is a bicuspid leaflet, so it has two leaflets, which again open on either side like this during the time when the diastole, the flow is occurring. And during systole, these two leaflets will stay closed. I've not shown a closure picture here, but just so you can imagine that the leaflets will close, and as a result, they are very, very physiological, and there's very minimal mitral regurgitation here. So this is more physiological, the St. Jude's variety by leaflet type. Now, do not forget the bio-prosthetic ones, which I've listed here, and they are the porcine or bovine type. And they're Carpentier-Edwards. They are, again, all these names are after the authors or the surgeons who helped develop these innovative technologies of the valves. And so Carpentier-Edwards, the team, they did the porcine and the bovine type. So the advantage clearly are with the bioprosthetic valves is you don't need to anticoagulate unless you have to because of atrial fibrillation. But in that case, they give you a mechanical valve which is more durable. So mechanical valves, more durable, that's the pros and cons, but requires anticoagulation. Bioprosthetic valves, not as durable, although they are making very durable ones now, but do not require anticoagulation unless you really have to later on because of atrial fibrillation, etc. Also, bioprosthetics can be placed in setting where in younger individuals like 25, 30-year-old females who are still in a reproductive stage and age, their anticoagulation could be an issue, so porcine and bovine types will be very, very helpful till they reach menopause, and at that point, again, porcine bovine can be replaced permanently with a mechanical valve. So in a nutshell, you learned in this video vignette what are the indications, how the procedures are entertained depending upon what the indications are. And just so that you know, the calcium valve, calcium on the valves, the fibrosis, the subvalvular fusion, and severe MS and MR, I forgot to mention. Severe MS and MR, if that is present, again, you're better off getting a mitral valve replacement, either a mechanical or bioprosthetic. Okay? So those are the three types, the Starr-Edwards, the Bijak-Shiley, and St. Jude's. Okay, and let's talk more later on some more intricacies as we get to know mitral stenosis and the mitral valve conditions. Thank you for your attention, appreciate, and looking forward to meet you again. Bye.